Thanks very much. Hello everyone, thanks for coming along to listen to us today. We'd like to speak about an in-depth review of cancer pathways which we undertook in NHS Midlands and Lancashire. So my name's Ruth Green. I'm a lead consultant analyst with NHS Midlands and Lancashire Business Intelligence Consultancy Unit, and I'm here today with Kelly Bishop, our Assistant Director of Nursing and Urgent Care, and Jo Bayliss, who's one of our Business Insight leads. So we're just going to give you an overview of the project and the approach that we developed that we'd like to upscale so that it can be adapted for other ICBs and regions. I'll give a quick introduction and context, and then Jo and Kelly will go into more detail about the mixed method approach that we adopted. So in terms of context, the programme of work was funded by by West Midlands Cancer Alliance, and we supported the Staffordshire and Stoke-on-Trent ICB to understand the variations in their cancer pathways and also identify areas for potential improvement. So this was all done in the context of national guidance, because as we know, the long-term plan ambition is that cancers diagnosed at stages 1 and 2 will increase to 75% of cancer patients by 2028. So really at the heart of the cancer pathway review, it was the drive to improve patient experience and outcomes. And hopefully as we go through the presentation today, you'll see how we've been able to capture the voice of the patient as part of this programme of work. So we looked at two main areas. One was a review of primary care urgent suspected cancer referrals, the second being an analysis of late-stage presentation and diagnosis. For both areas, we undertook a detailed analysis of both quantitative and qualitative data, and we incorporated an audit as part of the approach. Bear with me a second. So key to the delivery of the project really was the joint approach of the clinical and analytical teams. That helped with the design and completion of the clinical audits as part of the analysis. And it really helped us in terms of building relationships with key stakeholders within the acute provider, hospital trust, cancer teams, and within primary care, because we were able to have those conversations, at the meetings with those teams. They brought a blend of data analysts and clinical specialists, so it was great that we approached them with a similar team. So working in partnership with the ICB, the primary care and acute hospital provider cancer services teams, it meant that we could incorporate a wide source of data and information. And we obtained the required input from the clinical specialists as part of a case study approach. Throughout the lifespan of the project, we held regular stakeholder engagement meetings, and those included neighbouring ICBs as well. We also attended the West Midlands Cancer Alliance board meeting to just update them on our progress. And we gratefully acknowledge the input from all these stakeholders within this programme of work. So I'm just going to hand over to Jo now, who's going to go into a little bit more detail about the combined mixed method approach that we developed.
Thanks, Ruth. Hi. So this slide presents how the qualitative and quantitative data was intertwined and used to inform each stage of the project. One was dependent on the other. First, we gathered all published data sets relating to cancer to paint the picture of need in the ICB. Where data allowed, we benchmarked to England and identified which sub-ICBs, PCNs and GP practices were outliers. The data gathered spanned the entire cancer pathway, from the uptake of screening through to mortality rates. The published data was then used to inform an options appraisal to identify which cancer sites were to be the focus of the project. The options appraisal also included a review of NICE guidelines and included feedback gathered from the ICB and NHS providers involved in the project. And from this, 3 cancer sites were chosen. In-depth quantitative analysis was conducted for the 3 specific cancer sites identified in the options appraisal. This analysis included data sourced from ERS and published data from sources such as NCRAS, as well as data provided by the acute trusts involved in the project. The in-depth analysis included calculations of directly standardised referral rates, quadrant analysis of referral and conversion rates, geospatial analysis presenting referral rates by GP practice, late-stage diagnosis analysis, including cases diagnosed via an emergency route. Feedback from stakeholder conversations informed the content and approach of the clinical audits. Outputs of the in-depth quantitative analysis inform the sample sizes required for the clinical audits. And then finally, the final report was brought together, the findings of all the different elements and research of the analysis into one document. The report identified key recommendations specific to each cancer site that can be used by the ICB as a basis for developing an action plan. The report also highlighted topics that warranted further investigation. There we go. Pass you back over to Ruth.
Thanks, Jo. So just moving on to the project audits. An audit of a selection of referrals was included as part of the pathway analysis. And that was really to assess them for completeness, including compliance against referral criteria and the undertaking of diagnostics. So as part of that process, we developed key questions that we wanted to answer through the audit. I outlined the key ones there. So we were looking at gaps between optimal and suboptimal referrals, any delays in the patient pathway, also sort of what elements of the referral process add value for the patient and what is not necessarily needed. And also we captured the perspectives of primary care and the provider cancer teams in relation to the challenges that they experienced from the referral process. So I'm going to pass on to Kelly now, and she'll go into more detail about the late-stage case study approach.
Hi, so as Ruth said from the outset, this was very much about bringing that clinical voice and patient voice in from the beginning of the programme. And everything we did with clinicians wrapped around, that being myself or that being with the wider trust or primary care clinicians. So that absolutely informed the methodology of both the quantitative and qualitative approach. So this is a late-stage diagnosis case study, and I work very closely with the lead Macmillan nurse who helped design this. So basically, we got a long list of patients that presented to ED with a late-stage diagnosis presentation, and the clinicians reviewed that long list, and we did purposeful sampling. So picked out those that actually had a really good story to tell about actually, with the benefit of hindsight, how could we have done things differently before that patient presented? Actually, what are the symptoms that we might have missed as a healthcare system? And then work really closely with the clinical nurse specialists who then actually wrote those case studies, and for the patients that were still alive, because sadly some weren't, they had really in-depth conversations with those patients around what barriers they experienced to their access to healthcare that made them present late. So just move on to what those patients said, because this is powerful if you combine it with the analytics, and that gives you a really good rounded story. So we've done a word chart here, but just to give you a flavour of what the patients said. We looked at colorectal cancer in particular, and one of the many comments back from the patients presented late with cancer said that they didn't have the normal symptoms. Normally with bowel cancer, you expect to have abdominal pain, blood in your faeces, things like that. But actually, a lot of the patients presented with different symptoms of shortness of breath because they were getting anemia, and we don't talk about those types of symptoms. We know what to look out for, so the patients didn't know whether to present for them. A lot of them were presenting for lactulose because they were thinking they were constipated and trying to self-medicate. A lot had other things. Some put me down, well, I thought I was menopausal, or I've got IBS. So actually really associated it with other conditions that they had. So patients' attitudes to their pre-existing conditions was massive. And patients over the age of 74, through these conversations, were unaware that they were able to access bowel screening. So really valuable insight there. So we have run out of time. Sorry. So I'm going to flick straight to the contact details there that you can contact us on if you want to know any more about that programme. Thank you. Sorry.
Thank you very much. We do now have 5 minutes for questions, so if there's particular bits that you want to sort of shoehorn into the answer to a question, you're very welcome. So, Slido is open. Also, opportunity to put your hand up in the room, and I will bring you a microphone. Question on Slido is just someone asking about geospatial analysis and what work was done there.
Yeah, so with the geospatial analysis, that was looking at the referral rates by GP practice, but then mapping those geographically. So that was something that the ICB said that they hadn't actually seen before, so we could actually see referral rates geographically, and it was able for us to spot sort of like which areas across the ICB boundary where GP practices had higher or lower referral rates compared to others, and that's helping them direct some further work that they're looking at those differences in the referral rates by GP practice.
Thank you very much. Any questions in the room? Oh gosh, 2 hands already. I will come to the front one first.
Hiya. I'm sure I've read somewhere in the past that there's a connection between attendance for screening and deprivation levels. So did you do anything looking at health inequalities in relation to these?
Yes, so that was part of our first stage of the analysis, was to bring together a matrix of all of the available data that was published, but also doing that benchmarking against England, so we could see for those different geographies who had the higher or lower uptake for the screening, but we were able to bring in looking at the deprivation levels for each of those areas, as well as the 65 plus population, what proportions of those. So we could see along each of the geographical areas that we were looking at to see were there any patterns in terms of low uptake of screening or high levels of deprivation, or whether there was high proportions of 65 plus population but high referral rates for those practices or PCNs. So we brought all of that together.
Where was the next one?
So I have a vested interest because I'm in the NHS England Cancer Programme. So one of the things we've looked at is, when you were talking about the referral practices, we looked at use of routine versus 2-week wait referrals. Did you see any patterns drawn out from that? Were any GPs kind of using the cancer pathway more? Were they perhaps using the routine one, and then patients were later presenting as emergencies? Did you see anything along those lines?
I'm obviously not talking from an analytics point of view, but I did have stakeholder meetings with primary care to understand their viewpoints of why they might use the urgent suspected cancer pathway as opposed to get their perspective to go alongside the analytics. They did say, actually, I think the main conversation from them, they didn't use it to necessarily get the appointment quicker, which was kind of an assumption that they might do. But a lot of it was around the fact that there wasn't another pathway they need to go to. So a lot talked about the with the colorectal pathway, that they just didn't know where else to signpost them with sort of the non-specific symptoms. So actually, from those conversations, it highlighted that a clear and non-specific pathway would have given the GPs a different direction. So from a conversational point of view and those stakeholder events, that's what came out. I don't know if there's anything analytic-wise.
From an analytical point of view, we only looked at the what was the 2-week wait referrals, nothing wider than that.
Okay, I think there is a chance for one last question from the room.
There's a couple on did you require much further?
So on Slido, did you require any further data, or did you get what you needed from national metrics?
Sorry. In terms of what we had to do for report, we had all of the information that we needed to be able to complete the report. However, partway through the project, the NCRAS data did become available to us. So if we're to repeat this type of work, we would be looking at the patient level information next time rather than the published data set, which will allow us to do further analysis.
Okay, I think we are at time, so thank you again for an interesting talk. Thank you.